Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute myeloid leukemia with RUNX1, RUNX1T1 fusion. This is an acute myeloid leukemia that is found in about 1 to 5% of AML cases, and patients usually present with symptoms secondary to bone marrow failure, meaning that they can present with fatigue due to anemia, bleeding due to thrombocytopenia, and recurrent infections due to leukopenia. Morphologically, blasts are usually large with abundant basophilic cytoplasm, often containing numerous azurophilic granules and perinuclear clearing or perinuclear halves. And azurophilic means blue, and perinuclear clearing or perinuclear halves are one of the characteristic morphologic findings in this entity. Sometimes a few blasts containing large Chidiac Higashi-like granules may be seen. Our rods are frequent in this entity, and eosinophils and eosinophil precursors are often increased. Basophils and mast cells may be increased as well, and variable myeloid dysplasia can be seen. Now, let me share with you this case of a 50-year-old patient who presented with fatigue and was found to have blasts in the peripheral blood. So as you can see here from this low power, there is a lot of empty spaces between these red blood cells. So the patient is anemic. And as you can see here, I do see this large cell. So let me go high power to look at the morphology of this cell. Let me add some oil for better visualization. Here's our cell of interest. Let me go even higher power. So what I see now here is this large cell. It has high nuclear to cytoplasmic ratio. It has prominent nucleoli. This is one here, and this is another one here. And it has pink granules, and it has this hour rod and moderate amount of cytoplasm. Here on even higher magnification, you can appreciate this needle-like red structure, and this is our rod. Let's go around to see if we do have more blasts in the peripheral blood of this patient. As you can see, I passed a couple of fields and I don't see any white blood cells. So the patient is leukopenic. I do see this cell here. This is another blast. It has multiple prominent nucleoli, high nuclear to cytoplasmic ratio, and scant amount of cytoplasm. I'm going around and I don't see a lot of white blood cells in general. Some scattered lymphocytes. But not a lot of blasts. Now, let me show you the bone marrow aspirate smear. And let's start with the direct smear for better visualization of these blasts. Now I'm going around looking for some blasts. Here we go. Let me go on high power. This is what I want to show you here. We do have this blast, large nuclear to cytoplasmic ratio, moderate amount of blue cytoplasm, and this is what they call perinuclear clearing or a perinuclear half. So this is the outline of the nucleus. And then in this perinuclear area, we do have this clearing. And this finding is one of the findings that we can see in acute myeloid leukemia with RUNX1, RUNX1T1 fusion. This one here is another perinuclear HOF. Let's keep looking around. Let's go high power here. And this one here is a perinuclear HOF. This one here is a perinuclear HOF. And this one here is a perinuclear HOF as well. So as you can see, I do see some scattered blasts here and there. These blasts have high nuclear to cytoplasmic ratio, moderate amount of cytoplasm. Some of them have granules. Like this one here, you can appreciate the pink granules that I'm seeing. And this is a perinuclear HOF next to the nucleus. So this is the morphology of the blasts in this entity. Now, let me show you the speculated bone marrow aspirate smear. Let's go around. I'm looking for an area that has a lot of cells where we can appreciate the morphology. This is a good area here. And as you can see here in this field, I do see a couple of blasts. This is a blast here. That's the perinuclear HOF. This is another blast that doesn't have the perinuclear HOF. This is another blast with some pink granules here and perinuclear HOF. And these here are blasts as well. So we do see a lot of blasts in the bone marrow aspirate smear of this patient. And we ended up counting about 45% blasts in the aspirate smear in this patient. Now let's go back to our presentation. As for the immunophenotype for these blasts, they usually have high intensity expression of CD34. CD13, HLA-DR, and MPO are usually positive. CD33 can be dim or negative. And this acute leukemia is characterized by aberrant lymphoid marker expression, including CD19 and cytoplasmic CD79A, which are B lymphoid markers. BAX5 can be positive by IHC as well in this acute leukemia. And CD56 can be positive in some cases, and in these cases, it's one of the poor prognostic factors. Now, let me show you the flow cytometric findings in our patient. As you can see here, this is our dim CD45 population in brown. This population here, this is the CD34. As you can see, it's CD34 bright, or you can say we have high intensity expression of CD34 here. The lymphoid markers, T lymphoid markers, CD2, CD3, CD5, and CD7 are negative in this blast population. As you can see here, CD19 is dim, and CD56 is partial because we do have a positive population here, and we have a negative population here. And as we said, CD56 expression is associated with worse prognosis. And this acute leukemia in general is characterized by suppression of B lymphoid markers like CD19. As you can see here, CD19 is dim, CD20 is negative, CD38 is positive in our blast population, and CD10 is positive. Now, for our myeloid tube here, CD13 is positive, CD33 is positive, and CD117 is positive. CD123 is expressed in about 97% of the blasts, and this is helpful because we have targeted therapy against CD123. HLA-DR is positive, CD7 is negative. Now here, our monocytic tube, our blast population is negative for CD11b, negative for CD16, negative for CD14, negative for CD4, and positive for CD64. And lastly here, MPO is dim to positive in our blast population. TDT is positive in this population as well, and CD79A is negative in this population. So we do see expression of lymphoid markers in this acute myeloid leukemia. As for the molecular findings, translocation 821 would result in RUNX1, RUNX1T1 fusion, and low mutation burden is typical, meaning less than 2. The essential criteria to make a diagnosis include identifying a myeloid neoplasm with increased blasts in the peripheral blood or bone marrow, and the blast percentage may be less than 20%. That's okay. And the acute leukemia should not be fulfilling diagnostic criteria for myeloid neoplasm post-cytotoxic therapy. Detection of translocation 821 is a desirable criteria. And generally, this condition has favorable prognosis with intensive consolidation therapy, hyperdiploidy, and deletion 9q. However, poorer outcomes are seen with KIT mutations and CD56 expression. This is the end of this video, and see you next time.